right? First of all, I'd like to thank the Mid-Kansas Jewish Federation and Hadassah for setting up this forum. I have had a series of town hall meetings, and my experience has been that when I speak before the Chamber of Commerce, they become town hall meetings on healthcare today. So it is a very important issue. And I think from all my experiences, both in Washington and here in Kansas, everyone can agree on something. Healthcare does need reforms. And I think the question then becomes, how do we conduct the debate and the research and the solutions and get them applied to our culture and our society? Americans are compassionate people. We've seen this play out in many things. Tiffany explained to us how Hadassah has expressed their compassion. As taxpayers, you express your compassion when a tsunami hit Southeast Asia. Your government sent $1 billion to help people in need. But that really didn't express to me the compassion that Americans have. What expressed that compassion to me was the additional $1 billion that Americans gave after reaching into their own pocket, not through their government, but through their own efforts to try to help people in Southeast Asia. So we are a compassionate people. In every case, I think what Kansans would like to see, whenever we talk about reform, is that patients have to be first in that reform. That patients should have the opportunity to choose their healthcare provider, to choose their physician, to choose their clinic, their hospital whenever possible. So I think whenever we look at a solution, we have to have choices involved that puts the patients in charge and not take that ability away from them.
What if they can't pay for it?
Well, I think that's something we need to address, and that's one of the things I'm going to talk about later. But thank you for bringing that topic up. One of the things and I'll get to in just a second. Another thing is accessibility. It's important now that we have a system that is accessible to everybody, because that doesn't exist today. We have people that are denied health care because of pre-existing conditions. That's one of the problems that we have to address. Financing cost of individuals. Sometimes they believe they can't afford it, so we have to make it more affordable. And we ought to address the costs that could be avoided as well. And I think Dr. Michael talked about it with diabetes and living a healthy lifestyle. We can avoid some cost by living a healthy lifestyle. But our current system is designed to only address the sickness issues and not the wellness issues. So we ought to look at, in part of our reform, putting some incentives in place. Oh, I'm sorry, we're not supposed to get to the solutions yet. Let me move on to some more of the problems. I think that we have to talk about rationing as well, because rationing does exist today. It exists in the private sector when insurance companies deny care, and it exists in the public sector when commissions in Medicare, for example, like MedPAC, deny deny pharmaceuticals and care to some seniors. And let me explain. I had a lady come to my office this spring. She was from Overland Park. Her name was Jenny Joe. She was suffering from an immune deficiency. When I saw her, she was wearing a mask, and she didn't want to shake my hand. She said, "You know, Todd, you shake a lot of hands." And she was concerned. She was concerned about picking up another bug. Jenny was suffering from a pretty bad bout with the flu. Before she turned 65, her physician prescribed medication that worked for her. It allowed her to live a normal lifestyle, to play with her grandchildren, to shop, to go to ball games, to go to church. After she turned 65, she went to get reimbursed for that pharmaceutical, and Medicare said, "I'm sorry, we don't fund that. We have a more optimum version that we fund." Well, she thought that it was a generic, so she started taking it. Her problems started with headaches. It later moved to, which included muscle pain later on, mostly in her lower back, and then she caught the flu, and then she came to see me. In America today, no citizen should ever have to come to an elected official or a bureaucrat to get their health care. They should go to a doctor or a nurse or a clinic and hospital of their choice. So we do have rationing that exists in the private sector as well as in the public sector. And I think the last thing that I'd like to talk about is the dignity and value of human life. The second to last thing. That's another phrase that you could use. Right?
Before I conclude.
Before I conclude. Thank you for the phraseology there. The dignity and value of human life. What is the value of human life? What is your life worth? What is the value of your children, your spouse, your grandparents? What is their value? for me, it's a pretty high value. I value my father, for example, who's 90 years old. I value his life highly. Well, in the world today, there are systems that have put a value on human life. In the United Kingdom, they have an agency, it's called NICE, National Institute of Care and, I have it here somewhere, I have to think of it, but NICE, N-I-C-E is the acronym. They believe clinical effectiveness. Clinical effectiveness, thank you. The experts are here and they're weighing in. NICE has determined the value of a human life in the United Kingdom is $45,000. Their decisions on health care, whether they accept treatment for that person or not, is based on the value of that person's utility to their society. I don't want to see that in America. And I'm very concerned when I see some of the president's advisors, like Dr. Emmanuel. And I have a quote from him that I'd like to just briefly read if I can find it. He wrote in The Landslot, under an article published in 2009, the title was Principles for Allocation of Scarce Medical Interpretations. He wrote, the complete lives system has a use, a method of rationing. So he's one of the advisors, and if I understand his perception or his concept properly, he uses kind of a bell curve, where you have very little life in the beginning years, up to age 2, and then a very low life at the end, and a very high value life in between. And this is a societal value. So when do we turn the switch off for young children when they have a disease? When do we turn the switch off for elderly people when they have some complication? This is a person who's advising the president now. And I think it's a data point that we all need to concern. Whether the president and Congress takes that advice or not is yet to be determined. But it is a data point that concerns me greatly. The last thing I'm going to talk about is trust. Who do you trust?
Don't trust you. I'm sorry for interrupting.
Thank you.
You're taking money from the healthcare industry. It's time for you. Threw himself out.
He's very cooperative, and I thank you for his cooperation. But I think we should determine who do we trust in health care. You trust yourself to make the decisions. You trust politicians to read the bill before they vote on it.
Yes.
I read the bill. I have it with me. You're welcome to look at it afterwards. HR 3200. It has been changed and will be changed in the future. Do we trust politicians who say that it's un-American to dissent? Do we trust the government to make decisions about your future health care and health care provided for your parents? So I think trust is a very important part of this decision process, isn't it? And I think that's something we have to ask ourselves. Is the system that we're going to move towards give us the ability to trust those who are going to make the decisions for us, either us or someone else? I thank, again, for the opportunity, Rabbi and Tiffany, thank you very much. And I'm looking forward to first discussing solutions and then on to discussing questions.